Morning, Roberto.
Hi everyone.
Hi Roberto.
Hello.
Morning, Marius.
Hi
Hi.
Marius.
Good morning, everyone. We will begin quite shortly. Thank you all for joining us this morning. We'll give it maybe one more minute, and then I will introduce everybody and we'll get started. Okay, good morning, everyone. Thank you for joining this webinar, optimizing the mental health of the health and care workforce. It's great for you all to join us this morning at the start of European Public Health Week 2025. My name is Jason Maurer. I'm a mental health advocacy specialist working with the WHO Regional Office for Europe. And it is truly a pleasure to be co-hosting and co-moderating this webinar with my colleagues, Giulio Castelpietra and Cassie Redlick, who will be joining later. This webinar will be focusing on how the mental health and well-being of the European health and care workforce is being challenged. But more importantly, it's about shedding light on the innovative projects that are aimed at enhancing, optimizing healthcare and mental health care spaces as a workplace. We will be discussing in several presentations, as well as an exciting panel, the policies and practical actions that can address the replicability of these experiences across different European countries. So to start, I would like to introduce Charlotte Marchandise, the Executive Director of the European Public Health Association, who's going to talk to us a little bit about European Public Health Week and what will be happening later today, as well as over the next 4 days. So Charlotte, please, the floor is yours.
Thank you, Jason, and good morning, everyone. And thank you for joining us as we open the first day of European Public Health Week 2025. European Public Health Week has a full day dedicated to mental health every year for good reasons, but we are really happy to say that today the question goes straight to the heart of what matters. Who is taking care of the people who care for us? And we are all healthcare worker in health centers across Europe, but across the world, under pressure, understaffed and stressed and underfunded. And I'm really, really happy, and I think it's really important that we start this week with this very important question. I'll share some slides so that you know everything about European Public Health Week. So this week the theme is innovation for resilience, shaping a sustainable future. And the theme is also the theme of the statement we had during European Public Health Conference in Lisbon, because we have those scientific conferences, but our goal is really to see how we can bring the science to the communities, to the ground, to National Public Health Association for EUPHA, but also to WHO country office, and how we work together, because we want health and public health actions to be science-based, equity-driven, community-focused, and policy-aware, because public health is about people, justice, and resilience. This week is a particularly good year. I mean, it looks like every year is better, and that's good for public health in those hard times, and I hope it's is good for your mental health, that we know that we have events in 21 countries with thousands of participants expected, with 292 events across the 5 days, mostly in person. Some years ago, it was mostly online, and now we have lots of in-person events with some very cool events. You will have very important conferences, webinars, we have an opening in the parliament, but you have also dancing sessions and dancing sessions online, which is, I think, really interesting. We have daily themes, so today's mental health, we have global health, healthy aging, health equity and social determinants. Friday will be led by EUPHA Next, our next generation network, and their partners, because if we want to put youth people at the center, well, they have to be leading. So let's see what they have for us. And because when we talk about innovation, sometimes we keep it very AI, very data-driven, which is really important, but we also want to talk about low-tech social innovation, and we are hosting a hackathon, innovation for inclusive public health for people with blindness. So we're really happy that we are walking the talk of innovation with and for people. And today, it's the mental health workforce at the center, with the partnership of WHO, which is very important partnership for us at EUPHA, also with Mental Health Europe. And every year we're doing that. We have very, very important stakes for the next Commission agenda, for the next political agenda, and we're happy to do it together with you, because what we want to do is amplify the voices of public health and not speak each of us in our silo. And of course, we have the support of European Commission. So my message for the week is let's connect, reflect and act for a fairer, stronger and more resilient Europe, but together. So every time we can connect, every time you want to reach out to us, do it, because at EUPHA we're here for you. Over to you.
Thank you so much, Charlotte. And thank you for introducing the week and the exciting things that are going to be happening this week. I've had the privilege of coordinating the webinar for the last 2 years. For Monday, so I know how much interesting things happen this week. So thank you. Next, I would like to introduce my colleague, Dr. Lydia Lazzeri. And she will be introducing to us a little bit more about the theme of the webinar today, as well as the webinar series under which it falls, which is called Enough Waiting, Reshaping Mental Health Care. Over to you, Lydia.
Thank you, Jason, and a very warm good morning to all my fellow panelists, but also to those who consider the theme important enough to join us this Monday morning. I'm Lydia Lazzeri, the Regional Advisor for Mental Health here at WHO Europe, and I should say that I feel privileged, but also overwhelmed by the great responsibility of addressing mental health in those times of change. So supporting our countries on behalf of WHO Europe in those times of change. And I would like to dissect out of all those elements that are changing our region by starting with how COVID-19 shaped our understanding around a number of issues, including mental health of the health workforce. For those of you who are aware of it, WHO Europe established a technical advisory group for examining the mental health impacts of COVID-19 starting from early 2020. And a group of experts from all across Europe, including persons with lived experience, tried to see what the evidence was bringing. And of course, the times were shaking. The evidence was hastily created. Not all evidence was good quality. However, one of the themes that came very consistently across was that among the vulnerabilities, health and care workforce was suddenly on the spotlight for being particularly vulnerable so that their mental health and well-being was significantly impacted by COVID-19. That was something that came in the surface. It had been spoken before how health workforce is under stress and burnout, but COVID-19 made it so that the global health community started to not only reckon it, but also talk about how to address this. And from then, we also started to examine in WHO what is the evidence showing. And for instance, if we link this, what I just mentioned, with the fact that in the World Mental Health Atlas of the time, you know, WHO produces those series of mental health atlases every 4 years. What we had seen is that we had a drop, we had lost mental health workforce between 2017 to 2020. And it's alarming to see that we had lost Europe, all the member states of the European, WHO European region had lost by 13% of the psychiatric nurses workforce. And this is very important because at the end, we see that not only we have less people to look after our mental health and well-being as members of the public, but also the rest of those who remain are overwhelmed because they have to cope with an increased work volume. So, and that made us so that when we started to discuss with the European Commission, DG Santé, the European Commission, about how to support the implementation of the new EU comprehensive approach to mental health, one of the themes that we agreed with the European Commission to put on table was to support mental health and well-being of the health and care workforce, which is why you will hear later today about our initiative in conducting this survey for the first time of its kind and of its size, a survey on the mental health and well-being of the doctors and nurses of the 29 countries under support, which has 27 European Union members, and Iceland and Norway. So, but you will hear a bit more about that in a minute. That means that when we will have the recommendations, the report of that survey, will be able to formulate also recommendations and work with our partners and with member states, but also partners. And notably, I see on screen not only EUPHA and Charlotte, a very warm greeting and thanks for our long-standing collaboration, but I also see Julian Bisholt from the European Psychiatric Association. That is also one of the key partners, key stakeholders with whom we intend to continue working and addressing this. The list of EUPHA and EPA are not, it's not an exhaustive list. I know we have John Leader here from the EFPA. So just to say that the European Public Health Week is a wonderful platform to bring together all stakeholders that have the expertise, but that have also the leverage, so the power to bring change in our region. With this, I pass the floor back to you, Jason, and I'm super interested to hear the rest of this webinar. Thank you.
Thank you so much, Lydia. So before we get right into it, with two presentations from two of our speakers, I'd like to just say that at any point, please pop questions into the chat. We will have a designated time for questions and responses later in the webinar, but if you put it in the chat, then we will try to answer it either through text or in a live answer at some point. To start off today, I would like us to start with Roberto Mediavilla Torres, who works at the WHO Collaborating Center for Mental Health Services Research and Training at the Autonomous University of Madrid. Roberto is going to be talking to us about supporting the health workforce from research to policy. And he and his collaborating center took the lead on the running and are now analyzing the data of the survey that Lydia just mentioned. So Roberto, over to you.
Hello, everyone. Thank you, Jason. Very happy to be here and very happy to share with you my humble work over the past 5 years when I've been focusing on analyzing the mental health of health workers. I'm going to try and share my screen. If you hear 4-month baby, he might jump in at some point because I'm doing home office today. So yeah, just ignore it. One moment. Okay. Are you able to see my full screen?
Yes.
Lovely. Okay, so I'll try to be very quick. There's a lot to say, of course, about supporting the health workforce, especially now, 5 years after the pandemic, because before that, as Lydia mentioned, in a way, we almost didn't care about anything that could happen in terms of well-being and mental health. We just probably took our health workforce just for granted and thought that because they are the ones caring for us, who cares, and we discovered, unfortunately or fortunately, depending on how you want to see it, that it was important. As we were discovering this in the amidst the pandemic, there was also this huge work made by the WHO Regional Office for Europe, and especially led by the team of our colleague Thomas, who's also involved in the survey that I mentioned later on, where they try to draw attention into the big crisis that we were having in trying to retain and recruit health workers to meet the increasing demands for healthcare in the European region. Thanks to this is now a huge priority for stakeholders and for advocates. And since we are in the European Public Health Week, we know that we as researchers know that it is important to, of course, conduct evidence-based research and to be very clear about it and try to use the most robust methods. but we also need to be catchy, if I can say, and we need to reach policymakers, and we need to be able to translate our findings into real world policies, because otherwise our research, or at least my research, doesn't make any sense. Just to kind of give you one figure, if you want to keep it, is that since 2020, the different estimates of the probable prevalence or incidence of depression and anxiety worldwide among health workers is about 1/3. These are estimates that are, of course, based on self-reports. They are not actual rates of depression or anxiety, because for that you need to conduct interviews, and we cannot do that. But anyways, it gives us an overview of how important this topic is. So this is what we know so far. But as also I think Lydia mentioned before, most of this evidence comes from very low quality studies. Some of these studies are huge, and there are some international initiatives, but since 2020, most studies have been conducted in very small samples, very self-selected samples. So it's not very high quality data. And another important thing that we learned after the pandemic, and here I'm gonna focus just to give you an example in Spain, because that's my country, and here's where I was working in 2020. And if you remember, this was a very initial and important hotspot worldwide, because we had hundreds of thousands of cases of COVID, and it was right after Italy, one of the earliest hotspots. So we learned very early there that there were some workplace factors that could be actioned to improve, or to potentially improve, the mental health of health workers. And this helped us putting some responsibility into policymakers and into decision makers and into managers. For instance, we learned that health workers who were forced to take decisions on triage, and who were kind of, I'm not going to say forced, but who had to prioritize patients because there were not enough ventilators in ICUs, they reported worse mental health. Same happened with health workers who simply didn't have enough protective equipment, like facial masks. And the same happened with health workers that were infected with COVID-19. If this is not important enough for decision makers and for managers, there's one finding that, and this comes from a large series of studies even prior to the pandemic, that shows that poor mental health is linked to turnover intentions. And if you remember my first slide, we are having a huge problem in the EU, and we need to do as much as we can to prevent nurses and doctors from leaving their professions. So if it's only for that reason, very practical reason, I think there's something that needs to be done. I'm just going to show you what we did in one of our studies. This was an EU-funded study called Respond. And here we took an approach at the individual level to try and support health workers. We just took a sample of health workers in Madrid and in Barcelona, two major cities in Spain, and we offered them a scalable stepped care program that was based on WHO interventions that we adapted and created digital versions of it. So we offered health workers to be part of this psychological support program, where first they could use a smartphone app, which included a stress management course called Doing What Matters. This is what DWM stands for. And then they could use PM Plus, Problem Management Plus, which was a peer-delivered support through video conference, more close to what we can think about when we think about psychological support. Our findings were actually very good. You just need to look at the upper left of the figure that I'm showing you right now. We found that at 2-month follow-up, so even 2 months after completing the full intervention, health workers kept reporting decreases in anxiety and depression symptoms, and decreases that were moderate to large. Because of everything that I mentioned before, we believed that these results were very important, so we wanted to publish them as soon as possible. And because we wanted them to translate into real world policies, we applied to, or we, I don't think applied is the right word, but we wanted to put it as part of the best practices portal of the European Commission. So right now, not only this intervention, but the whole process that took us to deliver this intervention, from adapting it to actually delivering it, to testing it, and to trying to scale it up in the healthcare system, is available at the European Commission's best practice portal, just in case any other countries, any other partners, whoever wants to do something similar or a similar initiative to care for health workers. But I might say, and this just takes me to the last part of my presentation, and even probably more important than having things that work to support health workers, which is of course important, what we need if we want to influence policymakers is high quality data. And as I mentioned before, this is something that is missing across many countries in the EU. What Lydia mentioned previously is that the WHO Regional Office for Europe, along with the European Commission, put in place this huge survey across the 27 EU countries plus Iceland and Norway, where we asked health workers about their mental health status, and particularly anxiety symptoms, depression symptoms, and drinking problems, because we also believe that drinking was very important. And we also asked health workers to report on the different stressors that they were exposed to at their workplace, whether they had enough support from their colleagues, or whether they had been exposed to violence at the workplace, including harassment, bullying, and any other things. And also we asked them about more positive things, such as specific protocols that they could have in their workplaces in place to prevent, for instance, violence or harassment. And we also asked them about well-being, because we thought it was very important not only to estimate the prevalence of probable mental health disorders, but also we wanted to see whether they had well-being levels comparable to other professions or to the general populations. The survey is now closed. It's being analyzed, so I don't have any data yet. I can only show that we got 122,000 responses across the countries. This is more or less the number of responses from doctors and nurses that we got across countries, doctors in purple and nurses in green. There have been some countries where sampling worked very well, and people were very engaged. There were others, because there were other countries where some other initiatives were ongoing, or maybe ministries or agencies were less responsive, so we got less collaboration there. But anyways, we are now working on a full-scale report that I guess will be out soon, and hopefully next year we could be talking about specific data in this Public Health Week. So take-home messages: poor mental health is linked to turnover intentions, and probably with retention, right? Because turnover is linked to retention. Actionable workplace factors might have a positive effect on mental health. Scalable psychological support can be delivered to health workers with psychological distress. And WHO Europe is now mapping doctors and nurses' mental health using this survey that I just presented. And I will be very happy to take questions at any time, or even if you want to email me, please feel free, and I'll be very happy to answer. So thank you very much.
Thank you so much, Roberto. We need to unfortunately move on, so I can't ask any of the very interesting questions that are happening in the chat. But Roberto, if you could take a look there and see if there's any that you could answer, that would be really great. Next, I would like to introduce Marius Ungareanu, who is the head of the health workforce section of the European Public Health Association, and he will be talking to us about the mental health needs of healthcare workers and when evidence does not guide policy, with some experiences from different European countries. Marius, the floor is yours.
Thank you so much, Jason. And I just want to make sure that you are seeing my screen now.
We see the presentation mode, but yes, we can see your screen.
Okay, excellent. So thanks so much for the invitation. I'll try to be quick because I'm more interested in the conversation that we'll have today. And what I'm going to present is just some brief findings of a paper that I published together with colleagues in a number of countries, and you'll see the details. And as you said, we looked at the needs of the health and care workers, and we wanted to see to what extent the policy is following these needs and addressing them. We wanted to look at the interventions that are taking place, and we also had a multi-layered approach because we looked at the multiple levels of governance based on a framework that we developed together with the colleagues in a number of countries. And we've done this because after we have experienced the COVID-19 pandemic, we have seen that there was this tendency to see lots of the needs of the health and care workers which surfaced, and to which maybe our health systems and our healthcare organizations did not pay attention to. And so, as I mentioned, based on the framework that we developed, looking at the multi-layered governance approach, we wanted to see which are the levels where initiatives can take place, and also what would be the strategies that would be effective in increasing the mental health support that is provided to health and care workers. We followed this qualitative approach based on the case study design, and we utilized a matrix, as I mentioned, which had a multi-level intersectoral governance approach. The countries that we have taken into our study were Germany, Portugal, Romania, Switzerland, and the United Kingdom. And I have to mention that we did not collect any primary information. We only used secondary sources, and we relied on country experts to provide information that was relevant to the objectives of our study. Now, in terms of key findings, I chose to show you this chart, which basically shows you the levels at which we were looking for relevant information. We were looking at the professions level, we were looking at the organizations level, and then moving higher up, we were looking at the health system level, and then at the international level, or at the European level, since all of the countries that we have taken into our study were European countries. And as you can see briefly in this chart, we have seen that at the professions level, we have seen maybe the least amount of interventions. We've seen that most of them were related to raising awareness, but in the same time, we had identified poor education and training initiatives, a quite serious lack of interprofessional collaboration and action. I forgot to mention at the beginning that we focused primarily on two professional categories. We focused on doctors and nurses, which is indeed a limitation. So we are not able to speak of all the professions. And focusing on these two categories, we did see some support in doctors, but less support in nurses. At the organizations level, we've seen in the countries that we studied that there was an extent of psychological support through the manner of helplines. However, there was not enough attention to how the work is organized, social support for health and care workers, or the needs of the children of the health and care workers. And of course, something which is a lot more worrying is that there was not enough action against gender inequality, discrimination, and violence. And violence against health and care workers is something that we have also extensively analyzed. At the health system level, there was little action, but the focus was mostly on the health labor market needs and the patient needs, with not enough coherent strategy allocated to health and care workers. In some countries, there were salary increases, but mostly for some categories in the nursing profession. Where we did see a bit more action and initiatives was at the international and European level, with policy guidelines being put in place, with global networks, and I believe that goes in line with what Roberto presented a couple of moments ago, and with a couple of EU policies that meant to provide support to health and care workers. So in all, we see two things. We see that there's a growing need for the health and mental health of the health and care workers, but in the same time, we see that the level of the need is not reflected by the actions that are being taken in order to address this. We address this conceptual framework that I presented before in order to help us have a more systemic approach on the issue of mental health of the health and care workers, and to pay attention to the multi-level governance of this. And we identified that the inaction and inadequacy in addressing these matters happens across all the case countries. You've seen that the countries are very much different in terms of resources allocated, in terms of the arrangements in the health system organization. However, we've seen that inaction and inadequacy crosses all the health systems analyzed. Basically, there are serious governance gaps, and there is a lack of coordination between the relevant sectors in order to address this. And as you could see, the weakest and the most unsustainable action was found at the national and regional level, with a lot more interest and action at the European or international level. And so I will just close saying that based on our findings, we need to do a lot more. We need to focus and coordinate our actions, but in the same time, we need to have this multi-level governance approach in order to not miss any of the levels where the needs of the mental health and care workers can be addressed. I'm adding here the link, and I can share the presentation because, as I mentioned, this is an article that has been published in the International Journal of Health Planning and Management, and I'm more than happy to share the presentation so that it can be further shared with participants. Thanks a lot for having me today again, and I'm looking forward to the conversation based on all of these presentations. Back to you, Jason.
Thank you so much, Maria. That caps off the speaker section, and now I will hand over to to my colleague Giulio, who's going to be moderating the panel discussion. Giulio, over to you.
Thank you so much, Jason, for introducing me and for the moderation of this first session. And thank you, Roberto and Marius, for the wonderful presentation. So it's a pleasure to be here today to facilitate this panel intervention and help extend our discussion on the importance of mental health and well-being of health and care workforce. For dealing with this, I am honored to present 6 experts who will bring very precious thoughts and experiences on this subject. So in this panel discussion, there will be Migle Trumpitskaite. Sorry, it's very difficult, the pronunciation of surname. She's a pediatrician and vice-president of the European Junior Doctor Association from Vilnius in Lithuania. Julian Bizold, a psychiatrist. He is working acute inpatient ward, but he is also Secretary General from European Psychiatric Association. He's based in UK. Morgan Lucy, head of an employee assistance service from the Irish National Health Service. Ajita Melbarde Kelmere, Department of Nursing and Midwifery from the Riga University in Latvia. John Francis Leader, he's the Board of Directors of Liaison for Mental Health, European Federation of Psychologists Association, and Karile Levikaite, psychologist and vice president of Mental Health Europe. So, as Dr. Mediavilla outlined so clearly, the mental health and well-being of health and care workforce is a very frequent and acknowledged issue among professionals. And as Dr. Ungureanu pointed out, there is more effective action and coordinated policies levers that are needed. So the research presented is extremely important to better identify the main issues. In this session, we will try to revisit these issues from many different perspectives. So let's begin with talking of most important problems affecting professionals' mental health, which seems to be more and more present also in colleagues who are approaching the career. So Dr. Trump Piskaite, from your work with junior doctors, have you seen shifts in core professional values such as work-life balance, career aspiration, that impact both moral and retention among early career physicians? So the floor is yours, Migle.
Hello, everybody. It's very nice to be here. I think it's a very important topic. We all think as junior doctors, and we thank you that you're involving us in this discussion. Also, just very briefly, I want to congratulate every nurse on International Nurses Day today, because I'm now at work. Nurses are running around, and I'm very happy to be working with a lot of amazing colleagues. So coming back to your question, yes, as Junior Doctors Association, we have observed a big shift in the professional values of junior doctors across Europe. And that and it does affect morale, and it does affect retention. We have 1.5 years ago, we have published a report of our qualitative study from tradition to transition. And one of the most interesting findings was that there is this huge generational transformation of how junior doctors perceive their careers in general. Previous generations were more often placed, like they did place the work at the center of their identity, let's say, and today's junior doctors are more likely to prioritize their own well-being, family life, meaningful professional development, and stuff like that. So this shift we could see in the report, it did happen, but it's not about the lack of commitment from junior doctors. We can see also from the same report that junior doctors are still very motivated and very passionate about work, but they are not willing to sacrifice their mental health or personal lives just because they have a pretext of vocation. So overwork and poor working conditions and wrong maybe culture and silent endurance is not anymore appreciated. It's being challenged by junior doctors, and they are unwilling to accept unsafe working hours. And we're currently working on that topic. They are unwilling to accept lack of rest, of being a cheap labor, let's say. And this is not just a change of mindset, but this is also accompanied by increasing resignations from clinical roles or from healthcare altogether, or shifting from one specialty to the other where these working conditions may be, and job satisfaction it's on a better level. In some cases, junior doctors are even quitting healthcare altogether immediately after graduating. So that's very important to know too. And they are opting for another options, other works, other specialties that can actually that value their skills, that their workload is manageable in those sectors and stuff like that. So it means that burnout, stress, and inability to balance personal or professional life for junior doctors is not just a personal problem. It's a systemic loss, let's say, and the system is losing the doctors that could be treating our patients, and the need of doctors, of medical workforce is increasing. So it's like a vicious cycle, and it's a direct connection between poor morale and workforce attrition. So we do address this issue amongst junior doctors. We think that as future doctors, we have the responsibility to talk about that, talk about factors influencing job satisfaction and mental health in particular. So I don't know if I answered your question, but it is a very important factor, the generational shift, and we are very happy that we're talking about this, and you also think about that.
Thank you so much, Migle. And yes, moving to nurses, that this is a good day to move. So they are also the professionals that are particularly affected by these issues. So Dr. Melbarde-Kelmere, could you share what are the most common reasons or barriers the nurses leaving the profession in? So the floor is yours.
Yes, hello. Thank you for invitation. Thank you for all previous presentations. It's my honor to be here. I'm a nurse with more than 24 years experience on the healthcare, and also I'm a lecturer and registered in universities, and I'm working with nurses and midwives. And also I'm board member of Latvian Nurse Association. So we really talking at least 10 years and more about the nurse burnout. And we have several studies where it's measured. And unfortunately, of course, the shortage of nurses in Latvia is also the same like in other countries. And statistics shows that approximately 1 of 2 nurses in Latvia works in several jobs at the same time. And unfortunately, the number of nurses in Latvia is dramatic. It's 4.6 nurses per 1,000 inhabitants. So there is a lack of work-life balance closely to our financial pressures and work environment and resources. And 2 years ago, Latvian Nurse Association, together with Health Ministry, created survey to point out or to understand which are the main barrier factors and also motivation factors for nurses in Latvia. And key barriers in our profession, according to this survey, is shift work, causing burnout. And I would like to note that in Latvia, we also working 24-hour shifts. And also nurses noted that the need for work in multiple jobs to earn sufficient, it's also the key barrier. And poor working conditions and environment, but maybe it's more about autonomy and profession prestige. So it is the main reasons for our barrier factors for the nursing professions. Thank you.
Thank you so much, Ajita, for these important insights. So now we are focusing on the mental health services, as also Dr. Lazzari remarked. Professionals are particularly affected by high staff turnover and workforce immigration in mental health careers. So I give the floor to Dr. Bithold. So that can tell us something on the reason behind this declining interest. So thank you, Dr. Bizzol.
Thank you very much and welcome everyone. It's great to be here as part of such a distinguished group of people representing the whole range of mental health professions and workforce. And it's great to be part of a WHO initiative, which is just part of the many important things that the WHO does. So to answer the question, I think there are two parts to my answer. The first is that of course, we are people who work, we are employees, so we're subject to all the usual push and pull factors that people experience. So things like pay, working conditions, the perceived status of a particular job versus other alternative forms of employment, and then, of course, regional and national economic factors. But all of these have this overriding issue, which is particularly of concern to us, of what we refer to as the brain drain. And this takes two forms. This is people moving from where they perhaps have studied or grown up to go and work somewhere else. And there are two forms. The one is from rural areas to urban areas, which affects, I think, pretty much every country. And the second is movement between countries. And you see particularly stark example of the impact of this, for instance, with Bulgaria, where after Bulgaria joined the European Union, they lost a huge percentage of the healthcare workforce who moved out from the country for various reasons. Now, there's a second part to this answer, which is that mental health is different from a lot of other healthcare work. And this is because of widespread societal prejudice and attitudinal issues regarding mental health workforce. And I want to give people some examples to make this concrete. Most people that I've met who work as clinicians in mental health care have encountered this question: why are you working in mental health? Someone as good as you is working in mental health rather than somewhere else, which is clearly reflecting the prejudice. The second is the poor facilities in mental health care compared to other forms of health care. In almost every country, if you visit the facilities for mental health services and you compare them to facilities for other medical specialties or other healthcare services, there's a stark difference. So underinvestment in mental health is a real issue, particularly if you look at that and contrast it with the economic cost of mental health problems to the economy. There's a disproportionate underinvestment in mental health. And again, this is true of most countries. The last point I want to highlight about this, we're subject to what's called the blame culture, where, for instance, if you work in cancer care and a patient dies despite all your efforts, then people appreciate all the work you've done. In mental health, if a patient dies by suicide despite all your efforts, there's a default that someone must be to blame. This is very different from other medical specialties and has a big impact on whether people in the profession. In terms of what we can do about it, just very briefly, because I'll probably talk on a bit more about this later, but what we can do about it. The obvious thing is investment. We can't get away from this. There needs to be better investment in mental health. There also needs to be attitudinal change. I just want to give an example that this really can work. In the UK, for many years, it was very difficult to get people to enter psychiatry as a medical specialty, as a specialty of choice. So the Royal College of Psychiatrists ran a Choose Psychiatry campaign to project a positive image and a positive message about psychiatry as a career, with the result now that psychiatry is actually the most popular of the medical specialties, or at least one of the most popular, and fewer than 10% of applicants can actually get a job in the specialty. So promoting excellence is very much the way to go to try and change things. Thank you.
Thank you so much, Julian, and thank also to the other speakers. because this is a very important point to understand the degree of problem affecting mental health of workforce. So let's now move to possible solution. That is also the reason why we are here. So we saw that there are several structural factors which can impact workforce mental health. So Dr. Levikaite, so I hope I pronounce it good. May you give some insight on how they can be properly addressed?
Okay. Indeed, I will make some repercussions, I think, to the previous panelists by vocalizing some issues, but also let's think about possible solutions. Indeed, addressing structural factors requires moving before short-term fixes. Actually, comprehensive and inclusive strategies should be embedded in the very design of the healthcare systems. And first and foremost, we need to improve work conditions, life and work balance, occupational safety, and fair remuneration across the sectors. And I think without doing that, which is foundational rights, not optional benefits, right? We can't move forward. So it's essential. Equally important is addressing mental health stigma. And despite the progress which is measured around the world, stigma still prevents many from seeking mental health support. And it's essential, to run normalizing psychological support and clinical supervision as vital to workforce well-being, not as a sign of weakness, which still exists. And I will get into to the solution proposed, not solution, but area of improvement. But also, I would like to also echo the previous panelist that mental health care professionals, they face attributed stigma. They are unfairly viewed as, I don't know, more damaged or diminished due to their daily roles, which can discourage them from seeking help themselves also often. And we must recognize that area too. And in this case, we can have campaigns and the stigmatization campaigns, very important, but leadership is the key. By creating culture that prioritizes mental health and actively reduces stigma, we can build a healthier and more sustainable workforce. So we have to invest into leaders in the different levels. They serve at different levels in this sector. Also, we must acknowledge and address moral injury, especially in mental health care, where staff may be required to carry out coercive practices. And these acts are often they're often in conflict with the professional ethics and personal values, and especially under resource settings with few alternatives. And exposing to such situations, workforce people, it can cause lasting psychological harm and also contribute to burnout, withdrawal, and departure from the profession. And I think in this case, we have to also change the systems toward more to employ rights-based approaches, right? And to rely on WHO quality rights mechanisms or UNCRPD, that's a Convention on the Rights of Persons with Disabilities. And furthermore, it's essential to address the various forms of violence that health and care sectors face, including all the forms, but also recognizing inappropriate power dynamics and rigid hierarchical models among workers, among professions sometimes. And this experience too often minimized or normalized, and they have profound impact on mental health, moral, and workforce retention. And policies must promote the local policies and the organization a zero tolerance approach to all forms of violence in the workplace, ensuring clear reporting channels, proactive mechanisms, and appropriate responses. And moreover, strategies must address challenging behaviors from third parties by equipping staff with de-escalation techniques and conflict resolution skills as part of comprehensive ongoing training. In general, we also need to prioritize accessible mental health support services, which should be tailored to the unique needs of different sectors within the healthcare workforce. And for example, mental health difficulties faced by emergency workers who deal with very high stress and in crisis situations regularly. They are different maybe from others, and we cannot afford one size fits all approach. We need to be creative, flexible, and to invest into new strategies, which are often could be based on digital or peer-led interventions, which are not yet recognized or developed in countries. And these initiatives can expand access to support, reduce stigma, and overcome traditional barriers, for example, like time constraints or logistical limitations, which are very often in the sector. Or peer-led support programs may create a sense of community and shared experience that resonates deeply with workers who may not feel comfortable taking some traditional forms of help and so on. And by embracing these innovative approaches, we could really build system which is responsive, inclusive, and effective in supporting for those who care for others. So that's the main approach I would like to share today.
Thank you so much. It's a very important insight. So now we have to move to Dr. Leader. So may you give some insight on how best we can care for and retain those with expertise?
Thank you, Julia, and thank you, colleagues, for such an important event on such a key topic. I think the central aim that we have in what we've been discussing is helping to ensure that career development in this space and well-being are not at tension with each other. They don't need to be, quite the opposite, actually. They should nicely complement each other, but sometimes they are. So I think that's what we need to be on the lookout for and looking to really design from the bottom up system. So that's not the case. It's the right thing to do, of course, to look after people who are looking after others. It practically helps with the points of turnover that have already been discussed. But also, very importantly, it matters in terms of outcomes, because mental health service provision is not a factory floor. There's a sense in which the quality in which the work is done matters significantly. It isn't just a question of quantity. So it's kind of a good problem, I suppose, in a way. It's good to recognize that no matter what angle you come at this from, it seems to point to the same direction of having care as a core part of how we approach this. So on a very practical level, some of the key themes, one which has been touched upon and always will be, is resourcing. So resourcing, of course, in some respects is to do with money, but it's about more than that. And just on the financial side of things, one interesting point to note, I suppose, is as we take a more psychosocial approach to mental health and well-being, what that potentially means is there are different budget headers that resources can come from. Even the health budget itself, that's a set of budgets, but much more beyond that. When we look at societal development generally, I think we need to get creative on a governmental level when it comes to how we're funding psychosocial supports and interventions, and that hopefully can help with resourcing. Also, something very important is coordination, because sometimes we have a series of good services, but not particularly good integration between them, which we know isn't good for a patient or a client perspective, but it's just not good from an efficiency perspective either. So whether that's public and private or other variations. And of course, taking a community-oriented approach is a real central part in this. How to make sure that the healthcare system is doing some of the heavy lifting, of course, but the role of families, the role of communities, we're really sharing the burden and working based on our own competencies. And technology has been touched upon a bit as well. That's going to have a role to play there, not just in terms of interventions themselves, which may become supported by technology more and more, but in terms of navigating systems, administrative support, things like that. The goal, I think, is always to recognize what are a person's competencies professionally and how can we let them do what they're good at and be supported or scaffolded in the other areas that mightn't be their primary focus. So as we embrace the psychosocial approach more as well, I think we're going to have to recognize that there are a bunch of different competencies, and it's not that we overload certain people with an awful lot of tasks, some of which may or may not be a fit for them. I think creatively resourcing mental health care moving forward is a really interesting topic, because there's a lot of different kinds of expertise that can be brought in order to share the burden, which will be useful. So one of the point then was workplace conditions, and it's an extremely important topic, and it's really important we're thinking about that socially as well as environmentally. So it is the space that we occupy, it's the tools and the equipment that we have available to us, those systems. But as been mentioned as well, it's also the social dynamics, it's the power dynamics, it's the collegial environment, it's interaction, of course, with service users, really giving that attention. So essentially the point here is a culture of care, not seeing that as something that's an add-on, something that's a kind of a nice to have, something that we'll get to at a later point if everything is in order. To do that would be a little bit like being a taxi driver and say, well, you know, if I make enough money this month, then I'll put fuel in the vehicle. Then I'll maintain it, then I'll look after it. It's not the kind of thing that can hopefully happen in the future. It's the kind of thing that's needed right now, that culture of care. It's both the right thing to do, but it will actually look after the system and be more efficient in the long run anyway.
So thank you so much, John, because this is an important framework. So looking to leadership, that it seems a key issue when addressing systemic barriers to mental health support for healthcare workers. We move to Mr. Lucy. How can effective leadership address these barriers, and what happens when such leadership is absent?
Thanks, Giulio. Just to echo what other people said, it's such a rich discussion, and what I want to contribute to it is that, I suppose, from my perspective, is that I manage all of the psychological support services for doctors and nurses and the rest of the health and social care workforce in Ireland. We provide access to 24-hour talk therapy, and I want to talk briefly, that's, I suppose, just framing what I'm about to share. I want to talk briefly about what we mean when we talk about systemic barriers, and then we'll come to the leadership piece. So there can be many systemic barriers, and what people tell us in the service that we run, the nurses and the doctors and other healthcare workers, is that what they need most of all in terms of optimizing and improving their mental health in the workplace is they need what are called the so-called secondary factors to be done well. So the human resource factors. How are we setting up the workplace to support them in a high pressure work environment? And some of the things are so elementary that they're often overlooked in workplace mental health initiatives. I'm talking about having access to break rooms, being able to access annual leave, having access to convenient childcare so that they can have a work-life balance, destigmatizing accessing mental health services in the workplace. So the whole idea of normalizing reaching out for support, that idea that it's actually just good professional practice to do it in 2025. It's not a nice to have. All of those pieces, workload management systems, safe staffing levels, all of those have a direct and significant impact on nurses, doctors, and other healthcare workers in terms of their mental health in the workplace. So that's what we're talking about when we say systemic barriers. They can be very, very concrete, ordinary factors. Why are they important, and why is the leadership piece so significant? Because leaders set the tone. Leaders decide on resource allocation. They decide on the funding for staff counselling. They decide on flexible scheduling and rostering, people talked about all the various kind of factors that feed into this. Getting those basics right is one of the most important factors in addressing the systemic issues in terms of having a robust mental health service in the workplace. And strong and compassionate leadership encourages mental health solutions in every jurisdiction, in every organization. And I'm talking about things like sponsoring and supporting new strategies and evidence-based initiatives. I'm talking about communications programs to destigmatize accessing mental health support in the workplace, burnout prevention initiatives, peer support systems that are using the right models for the right type of service setting at team level, but also hospital level and national level. And I'm talking about some really concrete things like having robust, well thought out workplace stress prevention policies and the tools that go with them. So, workplace stress risk assessment tools that managers, nurse managers, doctors, consultants can easily use, and that they're in place and they're being meaningfully implemented. So essentially what I'm describing in a nutshell is a kind of where there's systemic layered solutions that are being coordinated properly and have been carefully thought out. You also asked me about the consequences of inaction. So without that kind of strong, informed leadership where they're demonstrating a nuanced understanding of the requirements of delivering, an impactful, high quality set of mental health services or staff support services, if that's not in place, what happens is workplace mental health levels deteriorate. Several of the speakers already talk about that. That can lead to higher turnover, intention to leave, and consequently, the knock-on impact can be more errors and worse patient outcomes. So and the initiatives that are being put in place can seem tokenistic and not have much real world impact. So it's absolutely critical that you have strong, well-informed leadership who have a nuanced understanding of mental health support in the workplace. It's essential to enhancing that overall umbrella and package of mental health supports. Thank you.
Thank you so much, Morgan. So we are turning to the second round of questions. So I just ask to all the panelists to really be in 2 minutes because we are running a little bit out of time. So Dr. Trump Skyte. Sorry, it's very complicated. What specific actionable measures do junior doctors themselves propose to improve working conditions, job satisfaction, and overall well-being? And what role should hospital regulators and policymakers play in bringing these proposals to actions?
Thank you. Well, I will be very brief just because I'm very happy to hear that Dr. Levitskaite, Dr. Leader, Dr. Lucy, they kind of mentioned everything that junior doctors definitely agree with. And based on our reports and our community response to that, we can hear that everything that you just said, from working conditions to stigmas, are very important factors in job satisfaction and mental health. Generally, first of all, we just think that the workforce planning has to become a central health policy priority, and that's the most important thing, and acknowledge that the mental health of healthcare professionals is a very important factor here. Of course, the most urgent changes that have to be made from junior doctors' perspective, we feel it's working conditions, and we were talking about monitoring workloads, enforcing limits on working hours, flexibility of scheduling, adequate pay, of course, but also for junior doctors, one maybe different factor from all the other professionals would be a protected time for training and academic growth. That means that for junior doctors, in our report, we found that learning is often sacrificed due to service pressure. And we think that hospitals and clinics must structure time for supervision, feedback, development, and avoid excessive paperwork or night shifts for junior doctors just because of lack of staffing. Of course, the shift in work culture, I cannot agree more about what others were talking about. And I think, well, now in terms of responsibility from the hospitals, regulators, or policymakers, I would say that first of all these should understand very clearly that the well-being of junior doctors and nurses altogether is directly connected to the quality of care and patient safety that they provide. So maybe that's a bit of a motivation for everybody. And then what comes out of that is, of course, in the hospitals, the scheduling, the supervision, the practical support. The regulators should enforce those standards of training quality, working hours, and fair treatment, and etc. And policymakers, as it was said before, must fund and structure systems the way that could support these initiatives that we were talking about before. So thank you very much, everybody, for your insights.
Thank you to you, Migle. It's also very important, your insights. And yeah, we move to Dr. Melbarde Kelmere. So according to your experience in Latvia, what international best practice could be adapted to improve nurse motivation and retention?
Yes, thank you for the questions. I would like to say that safe staffing ratios, legally mandated nurse-to-patient ratio, it's shown that it can reduce burnout and improve patient care. And Latvia could explore implementing these minimum staffing standards in critical care settings. And also the empowering nursing leadership and shared governance and evidence-based practice, because we should adapt principles such as involving nurse in decision-making and clinical innovations. Also, this strong work-life balance and social protection benefits. We already have several items I already mentioned also on the notes and answer to the questions, but our employer supports the maintained balance of offering these flexible work schedules and the possibility to create this monthly schedule according to the employee's needs and psychological support and health insurance, but also these ongoing opportunities and mandatory development. It should be clearly stated. Yes, thank you.
Thank you so much. Just a reminder for panelists, when you finish your presentation, there is sometimes some questions in the chat. If you can just answer, if you can, because this will facilitate, yeah, the time, especially. So we are turning now to mental health teams. So to Dr. Bitzold. So what practical strategy or best practice do you think could be adopted to promote resilient safety?
Thank you. Of course, it's a very broad question, so I'm just going to touch on a few things. The first is obviously investment is needed, and the broader issue of attitudinal change. But then more specifically, I think it's very helpful if teams have an approach of wanting to promote and value excellence. We shouldn't set out just to be there or just to complete the day. We should aspire to promoting excellence because that creates a culture of positivity. Organizational leadership, the points I would make is I think it's very helpful if organizational leadership is visible and responsive. And if they create a culture where the clinical staff feel that the leadership are there to support them rather than to just issue orders. The next thing I would highlight is teamwork is really important. Now, you can have a team where you have a group of individuals in an office, but they don't really work as a team. Or you can have a team where those individuals collaborate. For instance, they might meet together every day to quickly go through new and challenging cases that they're working with, where they can share risk, where they can share ideas, even share support for each other. And that kind of culture of teamwork is often a lot more successful than when people don't have that regular contact. The last point I'd really make is about creating a culture where all the staff in the team or in the organization really feel both valued and supported as part of the team, and where it's recognized as part of the culture that we're all human, we can all make mistakes, but when we do make mistakes, that's actually an opportunity for learning and to look at how we can improve and maybe change something to prevent the same mistake happening again. So creating that milieu in the workplace where people feel really valued and really supported can change things, even where there are very big resource challenges. Thanks very much.
Thank you to you, Julian. This is a very important insight. And just move to Dr. Leader about digitalization, because this is becoming extremely important in this context. So if you may give some hints on what is its role in the future mental health workforce.
Digitalization, as you say, is a very important area, and it's something EUPHA, European Psychology, has been giving a lot of attention to, as I'm sure we all have, and it's good to see interdisciplinary collaboration and coordination on this topic too. Digitalization, when it works well, is a very useful form of scaffolding, I suppose, for some of the goals that we've talked about, a way to help them. Really, one of the central pieces there is that it's service user or practitioner centered or orientated. Where it can go wrong is where there's a sense of expediency, where we kind of go, well, there's a system that will solve a problem. We can kind of send people over that direction and they can use a tool and that's it, and that's enough. And that person-centered essence gets lost essentially from the intervention. So I think that's where it can become problematic. But when it's used in the reverse way, when we start with thinking about the needs of the people that we're supporting and the needs of the people who are doing the supporting, and then we use it as a form of scaffolding around that, that's where I think great things can happen. And I think they are starting to. So scaffolding mental health supports can be done in different ways. One can be in terms of interventions themselves. They may be digitally mediated, like online communications and telehealth, things like that, but they also might be digitally supported within settings like hospitals and clinics and so forth. So various experiential interventions like virtual and mixed reality and AI-assisted approaches. There's some very interesting work happening. But I think one easy, and I use easy with regard to more complex ways, it's still not simple, but one easier win, I think, is just around navigation of our systems. If you speak to tech developers, one of the big things they'll say to you is, look, it's not just about the tool and what it does, but it's about the user experience of actually working through the tool. Sometimes a simple app that doesn't do very much, but it does it well, can actually be more important. So I think technology is probably going to help us a lot over the next while, particularly if we're taking WHO's recommendations about the importance of community-oriented approaches seriously, because we've got coordination challenges that come up. So to be able to work on the map or the user experience of working through and navigating healthcare systems, I think that's something that's very good for people who are using the services, but also good for practitioners themselves, and that can help with bandwidth. So final point on artificial intelligence, as that increasingly is developed, our goal there, I think, is really to have a complementary rather than competitive relationship with it. So it's really to ensure, again, like the airline pilot example that's often used, but it's a good one and it stood the test of time. It doesn't substitute the pilot, it supports and it helps them with their bandwidth to be able to navigate clearly. So I think as we develop these kinds of tools, it is an exciting time, but it really requires all of us to pay close attention to the topic and to make sure that we are keeping practitioners and the people they care for at the center of the discussion.
Sorry, thank you very much. And we are approaching now to the end of this panelist discussion. So there is evidence from the discussion with all our panelists that an integrated combination of mental health intervention may reduce burnout and improving psychological well-being among healthcare workers. So, Mr. Lucy, may you shed a light on intervention demonstrating the stronger evidence and how can leaders implement them cost effectively?
Thank you. Try and move. There's a couple of key concepts. I'll try and move through them quickly. That are, those key concepts are really central to anybody who's trying to answer that question. Like there has to be a focus on integration. So I would recognize, even as the kind of head of service for the talk therapy services, that single interventions are insufficient. If somebody's coming for mental health support, there has to be a package. Synergy is the key. So in the Irish context, for example, we have a national workplace health and wellbeing unit that coordinates the efforts of occupational health, the talk therapy services for healthcare workers. We do work on a stepped care basis where the health and safety function are doing preventative upstream stress prevention work, so that we're meeting our legislative duty of care as well. And we're also working with human resources. So all of those pieces are being coordinated to maximize the efforts in terms of optimizing or being proactive about mental health in the workplace. Whatever we're delivering has to be evidence-based. So just very much in line with the WHO 2019 guidelines on mental health at work, whatever we're doing demands data-backed solutions. Well-being can mean everything and nothing. So we need to be really careful that we're using evidence-based wellness programs if we're introducing new initiatives. The other piece is practical implementation. So whatever we're introducing, there's lots of great reports and initiatives that are gathering dust on shelves that are never properly operationalized or implemented. So it compels us to consider feasibility, cost and scalability, for example. I'll give you a practical example. So with the employee assistance program that we have in the Irish Health Service, we have a small specialist internal team, and we have a large network of sessional contractors. So that's called a hybrid model, and it allows you to scale up overnight if something like a pandemic comes along. And it also helps leaders to manage the cost and predict that and map it out years in advance. The other thing is staff need to be given choice. So they need to be given telehealth options, face-to-face options. Most healthcare workers want face-to-face therapy if they're coming for assistance. Same with occupational health. So we need to give them choice. And I touched on this earlier, but it's really important. Stigma reduction and culture change. Leaders set the tone on this. Leadership is critical to this. Organizations need to look at awareness campaigns that run periodically over time, where we are normalizing the idea of reaching out and seeking mental health support in the workplace. And we're getting that message through that it's actually just good professional practice, not for those who are in trouble, but that you put gas in the tank before you run aground, and that we're training managers with the soft skills to recognize and respond to that distress when they see it in staff. So that's it. Thank you.
So thank you so much, Morgan. There is also a question for you in the chat, if you just can take this, because we probably, I'm sure we don't have time for a question and answer directly, because the time is really few. So we move to the final intervention. So it is crucial also to highlight the role of a right-based approach to reshape our understanding of workforce well-being in the health and care sector. So, Dr. Livikaite, may you spend some words on this?
Yes, some words on a very broad topic, but in general, rights-based approach is something which concerns both healthcare workforce and people who are served. And there are many important factors like safe, fair, non-discriminatory, and working environments. And also mental health as a right, not as some nice thing to have, but mental health as a right of person is in the center. And all the policies should be created not just, to offer something in time of crisis, but, the sustainability and is the key. And maybe one thing I would like to just a little bit touch upon is that the healthcare systems must be designed with co-creation, peer support, and inclusive governance at their core, ensuring that workers have a voice in shaping the environment they work in. But also it extends to the service users in healthcare. When healthcare workers, rights and well-being are respected, then stronger position to provide high quality care, and vice versa. Healthcare workers should be aware of the rights of those they serve. particularly the principles outlined in the United Nations Conventions of the Rights of Persons with Disabilities. By understanding and upholding those rights, workers ensure a more respectful, inclusive environment in service in general. And ultimately, rights-based approach to mental health shifts the focus from asking, how can staff cope better, to how can systems be transformed to protect and promote the rights and well-being of those who care for others. And also the well-being of workers is inseparable from the quality of care of people. And when staff thrive, so do the people they care for.
So thank you so much. And with your speech, the panel discussion is finished. I really thank also to all panelists and speakers to have interacted, also our team to have interacted with all the people that are asking questions in the chat and the question and answer space. So thank you so much for doing this. So a very heartfelt thanks to all our panelists for their rich and inspiring contribution, and to all our speakers for their openness and insights, and to everyone here for engaging in this important discussion. So we are moving to just a couple of minutes of final remarks. So I invite to speak my colleague Cassie Redlich and Monica Brinzak, coordinator of the European Public Health Week 2025. So thank you so much.
Thank you, Giulio. Thank you, everyone. It's just been an absolute pleasure to listen to all of you today. On behalf of our mental health flagship team, I want to really thank all of you, the speakers, the panelists, all the participants for such an insightful and rich discussion today, including the really thoughtful questions that were put in the chat. I mean, I think for me, one of the greatest strengths of this discussion was that we had people from all areas of work for our team. So many of you in the room, both the panelists, but also the participants, many of you have worked with us across many areas of work for many years across the Pan-European Mental Health Coalition, in our work with mental health of the health workforce, workplace mental health, in our work to address stigma and discrimination. It's really equality rights. There's so many areas of work that come together here. You come from different perspectives, and yet I think there were really strong themes that emerged through the discussion. You know, this, and I'm going to quote many of you because there were just so many great comments today that, you know, really this issue is not about individual deficiencies. It's about systemic challenges, systemic losses at the end of the day if we don't do something about it. And so the solutions really need to be systemic and multi-layered and informed by high quality data, but including those data that reflect what healthcare workers actually want and need in their workplaces. So starting with things like commitment and investment and, you know, strong, compassionate leadership to address all these factors that we heard about. So working conditions, addressing stigma and discrimination around mental health and well-being, building leadership capacity to create a culture of care in healthcare workplaces, encouraging things that people want, like work-life balance, providing opportunities for professional development, ongoing learning. And I think something that came out in the questions really was that there is still a huge gap between what we know can and should work and what actually happens at the front line for healthcare workers. So there is still work to be done in closing that implementation gap. So thank you to all our panelists. So first, our amazing speakers, Roberto, Marius, then Migle, Julian, Morgan, Agata, John, Karile, thank you all. And I'll hand over to Monica Brinzak at EUPHA for final words. Thank you so much.
Thank you so much, Cassie. Thank you so much, Julia. Thank you so much, Jason. Thank you so much to all the speakers, and not the least, thank you so much to the attendees. I loved how lively the chat and the Q&A was. I really enjoyed the fact that people were asking a lot of questions. They were sharing emails in the meantime with materials and so on. That is amazing. It shows how much we need to work on this and how much our collaboration is needed. And I took a look over the years, and the European Public Health Week had a mental health topic in one shape or form since the beginning. So in all the editions, starting from 2019 until this year and going further, of course, we had a day dedicated to mental health, which shows that this is a priority, and this, regardless of how many years we've put into this, it still remains something that we have to work on, especially when we're talking about the people that are caring for others. Who is taking care of our caretakers? I've heard a lot of touchy words: burnout, work conditions. We are not being heard. We are discriminated. People were writing in the chat. This is something that we should really start focusing, and we should start shedding more light onto this. It's so important that we are here today. I'm so grateful for everyone that started their week, that started their Monday together with us. This is only the beginning of the European Public Health Week. Thank you so much for joining us. Thank you so much for all the speakers for your amazing contributions. And thank you so much for everyone that attended the webinar. Thank you.
Thank you. Thank you to all. And I think it's finished. So have a nice day to every one of us. Bye
Thank
bye.
you. Bye.
Bye, everybody. Thank you.
Thanks very much.
Thank you. Bye.
Bye.
Thank you.
Take care all.
Have a nice public health week.
Yeah.